The first incision is made for the camera port, which is often placed 2 intercostal spaces below where they're planning to insert the bar. This helps provide a clear view of the sternum and the mediastinum. The surgeon in this video makes the initial incision with the bovie, and then they insert a trocar to allow them to use a thoracoscope to look inside. They'll use the camera to take quick looks through the entire procedure to make sure the bar is being inserted correctly and no organs are being damaged. And just to note, the anesthesiologist will collapse the right lung prior to the scope being inserted. Now they're marking the intercostal spaces where they're planning to place the bars. A sizing device is used to help them determine what size of the bar they'll need. The sizing device is also easily bendable, which helps them to determine what shape they need. Now they are using the tabletop bending device to help mold the bar into the correct shape to match up with the sizing device. They'll double check the final size of the bar to make sure no corrections need to be made. Once the surgeon is happy with the results, they'll start using a marking pen to make small marks where they want the incisions to be made. They're now making their incisions using the bovie and what looks to be like maybe DeBakey forceps to help grasp the skin edges. They're using Metzenbaum scissors to help open up and spread the tissue. The pocket that they're making is going to be superficial to the pectoral muscles. The insertion device is now being placed through the intercostal muscle. They are using the scope to visualize where they are going. The device will follow the back of the sternum. Once the surgeon can feel it in the correct intercostal space, they will push it up firmly so it goes through the incision on the other side. Umbilical tape is attached to the insertion device and then pulled through the chest pocket that was made. The tape is then connected to the bar implant and will act as a guide while they bring it through the chest and out the other side. The bar is inserted initially upside down. A bar bender is now used to bend the edges of the bar so they'll properly fit inside the chest. Using the bar flipper device, the bar is turned around. The patient here is doing 2 bars, however 2 bars are not always necessary. It depends on how severe the pectus excavatum condition is. The same process, however, is repeated. A stabilizer plate is now being inserted. They are only placed on the one side and it helps reduce the chance of the bar twisting. The Met scissors are helping him guide the plate into place. The ends of the bar are bent a little more to help prevent the stabilizer from slipping off. A surgical steel wire suture is now passed through the holes in the stabilizer and around the underlying rib. The wire is tied securely and then cut with wire cutters. This helps keep the stabilizer from slipping and secures the bar in place. In this video, they inserted the 16 French drain temporarily through the camera port incision to drain out the excess pleural fluid that built up in the pleural space. They reinflate the lungs and press on the chest until no other fluids bubble out. They said it usually takes about 5 minutes. The drain is then removed and the incisions are closed. The subcutaneous tissue can be closed with a 3-0 Vicryl CT2 suture, and the skin can be closed with a 4-0 Monocryl FS2 suture. The incision sites are lastly wiped clean with a wet and dry lap pad and then covered with Dermabond and steri strips on top.